thalidomide is the effect that we're seeing with thalidomide is quite interesting. And as I said earlier, I think safety is the major concern. If we can in future prove that it is safe, then probably it will be the best alternative for children in especially low middle income countries where we still do not have access to drugs like luspatercept and metaviptide. So yes, but right now thalidomide should be restricted to certain situations if you're not able to transfuse a patient because of probably alloimmunization, or the requirement is so high, like if a patient has developed hypersplenism and the annual transfusion rate is so high that you're not able to chelate the patient well. Probably that's one reason, because thalidomide has shown its effect in reducing the spleen size, right? If your patient is, you do not have access to regular blood transfusions, there is shortage of blood and most patients are not transfused well, that's something that we would look at. And one particular scenario would be lack of availability of good chelation. A lot of drugs in low middle income countries are generic drugs, and we come across patients who have severe cardiac and hepatic iron overload. Desferrioxamine is not available or it's not accessible, then probably that's one set of patients where you would like to add thalidomide and see if you can come down on transfusions. And in future, as the body utilizes that iron for erythropoiesis, then that iron load may come down. So if you're not able to transfuse, you do not have access to safe blood, or adequacy of blood cannot be ensured, and if you cannot chelate your patient well, I think I would stick to that right now. But if you have good quality blood products, chelators available, then it's stick to the standard of care, regular transfusion, chelation. That's the standard of care as of today.